So, hello everyone. Myself Nikhil Manoj Kumar Dhanwani. Today we are going to learn about anterior pituitary hormones and the drugs regulating their secretion and inhibition. So, the topics to be covered today are growth hormone release inhibitors, prolactin release inhibitors and promoters, and gonadotropin release inhibitors and promoters. So, first of all, we will learn about the anterior pituitary hormones. The anterior pituitary gland consists of two cells, acidophilic cells and basophilic cells. The acidophilic cells contain somatotropes and lactotropes, which helps in release of growth hormone and prolactin, while the basophilic cells consist of thyrotropes, corticotropes, lipotropes, and gonadotropes, which regulate the synthesis of thyroid-stimulating hormone, which further relate to synthesis of thyroid hormone, adrenocorticotropic hormone, follicle-stimulating hormone, and luteinizing hormone. As we know, these are the important hormones which helps in menstrual cycle. So the drugs altering the anterior pituitary hormone secretions are here. The drugs that inhibit growth hormone release are somatostatin, octreotide, and lanreotide. Drugs that inhibit prolactin release are namely bromocriptine, cabergoline, apomorphine. Drugs that enhance prolactin release: chlorpromazine, metoclopramide, and risperidone. As you know, chlorpromazine is also used in antipsychotic, while metoclopramide is anti-emetic drug. Drugs that inhibit gonadotropin release, they are further classified into two: superactive gonadotropin release hormone agonist and antagonist. In agonist, we have nefarelin, triptorelin, casorelin, leuprolide, while in antagonist, we have ganirelix and cetrorelix. So let's start with growth hormone inhibitors. First of all is somatostatin. It inhibits the secretion of growth hormone. It is actually 14 aminopeptide hormone. It inhibits secretion of growth hormone, prolactin, and thyroid stimulating hormone, insulin and glucagon by pancreas, and of all gastrointestinal secretion, including that of gastrin and hydrochloric acid. The gastrointestinal action produces steatorrhea, diarrhea, hypochlorhydria, dyspepsia, and nausea side effect. Somatostatin consists of splanchnic, hepatic, and renal blood vessels. Somatostatin decreases gastrointestinal mucosal blood flow, which can be utilized for controlling bleeding, esophageal varices, peptic ulcers, which are mostly bleeding. But its analog octreotide is preferred nowadays because of its longer duration of action. Use of somatostatin in acromegaly is limited by its short duration of time, which has a half-life of about just of 2 to 3 minutes. Lack of specificity for inhibiting only growth hormone secretion, because as you can see in previous slide, it inhibits prolactin, TSH, insulin, glucagon also. The further new drugs like octreotide and lanreotide are used mostly nowadays. The octreotide is a synthetic octopeptide surrogate of somatostatin, which is 40 times more potent in suppressing growth hormone secretion as more longer acting. Lanreotide, after long acting analog of somatostatin, it is another long acting after the octreotide. It is indicated for pharmacotherapy of acromegaly. Acromegaly is hypersecretion of growth hormones, mostly in adult age. Prolactin also known as milk letdown hormone, regulation of its secretion. Prolactin is predominantly inhibitory control of hypothalamus through which a dopamine that acts on pituitary lactotrope by D2 receptors. A physiopathological environment, hyperprolactinemia is responsible for galactorrhea, amenorrhea, and fertility syndrome in women. In males, it causes loss of libido and depress infertility. The prolactin inhibitors are namely bromocriptine. Bromocriptine has a potent dopamine agonist activity, weak alpha-adrenergic blockers. Action of bromocriptine decrease prolactin release, increase growth hormone release. Levodopa-like actions produce nausea, vomiting, hypotension, and decrease GI motility as their adverse effect. Condition in which it can be used is hyperprolactinemia, as it is a prolactin inhibitor, acromegaly, Parkinsonism, and diabetes mellitus, specifically type 2 diabetes mellitus. Second drug is cabergoline. It is also a D2 agonist. It is more longer acting than bromocriptine. It is the first choice of drug. Remember, it is the first choice of drug for treatment of hyperprolactinemia. It has no teratogenic effect. Gonadotropins. Gonadotropins uses are amenorrhea and infertility to aid in vitro fertilization, male hypogonadic hypogonadism, cryptorchidism. Its adverse effects are ovarian hyperstimulation syndrome, multiple pregnancy, precaution puberty, and allergic reactions. Gonadotropin release hormones. So, it is further classified in two types. The first one is long-acting gonadotropin release hormone agonist. They only initially trigger the gonadotropin secretion, while later they desensitize and down-regulate the secretion of GnRH, which is a major side effect. The superactive gonadotropin releasing hormone agonists are used as a nasal spray, can be injected subcutaneous and intramuscular also. It also has a potential to be used as contraceptive for both male and females. Use of gonadotropin agonists for more than 6 months carries a risk of development of osteoporosis. Second drug is nefarelin. It is 150 times more potent than native gonadotropin releasing hormone. Its uses are assisted reproduction, uterine fibrinosis, endometriosis, central precaution, puberty. Its adverse effects include hot flashes, loss of libido, vaginal dryness, osteoporosis, and emotional inability. Next, we have gasorelin. The use of endogenous gonadotropin suppression before ovulation, induction, as well as endometriosis, carcinoma, and carcinoma prostate. An androgen antagonist, particularly bicutamide, is given concurrently for 3 to 4 weeks, where gasorelin is used for carcinoma of prostate. The next is triptorelin. It is long-acting gonadotropin release hormone agonist. Gonadotropin release hormone antagonist. There are 4 analogs of GnRH: ganirelix, cetrorelix, degarelix, and aberelix. The degarelix and aberelix are approved for androgen withdrawal therapy for advanced carcinoma of prostate. Inhibit GnRH secretion without cause initial stimulation. Ganirelix and cetrorelix are relatively short-acting. They inhibit LH surge, that is luteinizing hormone surges, during controlled ovarian stimulation in women and undergo in vitro fertilization. Their advantage over long-acting GnRH agonists include they produce quick GN secretion, lower the risk of ovarian hyperstimulation syndrome, achieve more complete suppression of endogenous GN secretion. So we are done with the topic. Here are some MCQs based on the PPT taught today. So the first one, which of the following is not an action of bromocriptine? Bromocriptine is the prolactin inhibitor. So the correct answer is option A. It increases prolactin release because it is a prolactin inhibitor. So the first answer is A. Route of administration of GnRH agonist is it is given by all the ways: nasal spray, subcutaneous, and intramuscular too. The action of nefarelin. Nefarelin, as you know, it is GnRH antagonist. So it is used in all of the above: uterine fibrinoids, endometriosis, central precocious puberty. Prolactin inhibitors are contraindicated in option B, dwarfism. Use of GnRH agonist for more than dash months carries risk of osteoporosis. So the correct answer is option B, 6 months. If it is used more than 6 months, it causes a risk of osteoporosis. So thank you everyone. I hope you have understand the topic. Thank you so much.